Welcome to tonight's General Practice Cancer Education webinar in collaboration with the BreastScreen WA. Breast density, what does it mean for GPs and their patients? That's the topic of our tonight's webinar. I'm Dr. Gordana Cook. I work as a GP and I did a PhD in breast cancer in immunopathology. Now, in the spirit of deepening relationships, I would like to acknowledge the traditional custodians and owners of the land, the Whadjuk people from the Noongar Nation, and recognize their continuing connection to land, waters, and community. I also pay my respect to their elders and extend their respect to all Aboriginal peoples living and working in this area. We encourage you to ask questions, and they will be discussed at the end of this webinar. You can submit at the end of the presentation your questions by typing via the Q&A function at the bottom of your screen. An online evaluation survey will be sent around after the webinar, and we do encourage you to complete this so we can continue to improve the education events we provide for you. I'd like to welcome tonight our guest speaker, Associate Professor Jennifer Stone. Associate Professor Jennifer Stone is a prominent international and national expert in breast density research and has a PhD in cancer epidemiology and biostatistics. As a National Breast Cancer Foundation funded Principal Research Fellow and the head of Genetic Epidemiology Group at the University of Western Australia, her research aims to improve breast cancer screening by accumulating translatable evidence through the clinical use of risk factors like breast density and body mass index to tailor screening and improve breast cancer outcomes through early diagnosis and primary prevention strategies. Associate Professor Stone is currently leading an NHMRC, a targeting cell for research project BreastScreen Plus, investigating a novel intervention targeting obesity-related barriers to mammographic screening. She is also CI on a recently funded NHMRC Center for Research Excellence, investigating precision public health approaches to breast cancer screening, early detection, and mortality reduction. Associate Professor Stone established the Australian Breast Density Consumer Advisory Council in 2019 to provide a community perspective on the research activities across Australian institutions interested in breast density research and breast cancer screening. Please, Professor Stone, we are welcoming you to our webinar, and we are all excited to hear news from you. Thank you very much.
Thank you very much for that very warm introduction. Next time I think I'll write something a little shorter. I'm just trying to open up my presentation here. Can everybody see, can you see that okay, Gordana?
Yes, I see, yes.
Fantastic. Yes. Okay.
Thank you very much. Yes, please go on.
I'd like to start with, this is a slide I've been presenting now for, I think, nearly 7 years, and it hasn't really changed much. I call it my top 10 things that I think that everyone should know about breast density. What it is, the white appearance of breast tissue on a mammogram, how it can be determined by feel or touch. It's a strong predictor of breast cancer risk. It makes abnormalities in the breast harder to see. It's very common. It decreases with age, tracks well over time, highly heritable, but still modifiable, and can be used as a biomarker to monitor effectiveness of primary prevention strategies. So I'll go through each of those in a little bit more detail, just to make sure that we're all on the same page. But then I'd also really like to talk about some of the things that we still need to work on, and more some of the latest research regarding the breast density measurement, screening recommendations for women with dense breasts, and the impact of breast density notification on women and on the health service, and a little bit at the end about personalized or tailored screening. So first of all, what is breast density? It's the radiographic appearance of epithelial and stromal tissue on a mammogram. Like I said, it cannot be determined by feel or touch. Here are 6 examples of it, where here we have in picture A, we have a very fatty breast. Fat is radiologically lucent, so it appears dark on a mammogram. Whereas in picture F, we have a very dense breast, and there's everything in between. So women with extensive breast density are at significantly higher risk of developing breast cancer than women of the same age, and I'll talk a little bit about why that's important a little bit later, compared to women with little or no breast density. So a woman in with say picture F compared to picture A, has a difference in risk about sixfold. It also makes abnormalities in the breast much harder to see. So this is a study we published in the New England Journal, where we compared women with greater than 75% density to women with less than 10% density. And you can see that overall, the relative risks are 4.7, sorry, around there. Then we split the cancers up into whether or not they were detected by screening or detected as an interval cancer, which is a cancer that was not detected at screening, but instead was detected within 24 months after a normal mammogram. And as you can see, the relative risks are very high for associated with interval cancers within 12 months after having a negative screening mammogram. So it's a bit of a double whammy. The tissue itself, dense tissue, increases the propensity for tumors to develop. And then if they do develop, it makes it incredibly hard to see. And that, of course, is because tumors are white and breast density is white. So numbers 5, 6, and 7, dense breast tissue is very common. This is a graph I really like to show. It's from Sprague et al. In JNCI, looking at the proportion of women on the y-axis. This is American population with categories of age on the x-axis. And then each of these bars represent the BI-RADS classification, which is a 4-category manual radiologist assessment of breast density, ranging from almost entirely fat, to scattered density, heterogeneously dense, and extremely dense. So, for instance, if you have, if you're a 40 to 44-year-old woman and you have heterogeneously dense, you're in a very large group, around 44% of the population. Overall, they estimated in this paper that about 43% of all women aged between 40 and 74 have heterogeneously extremely dense breasts. So it's very common, but of course, not all of those women will go on to develop breast cancer. And more about that later. Breast density decreases with age. You can see that all these bars decrease as age increases. And this might be a bit counterintuitive because of course your breast cancer risk increases with age. But that's because the true risk factor, when you're talking about breast density as a risk factor for breast cancer, it's your breast density for a woman's age. And if you're looking at percent mammographic density, it's also important to consider not only their age, but also their BMI. And finally, it tracks well over time. It's highly correlated over time. So women who have high breast density for their age at 50, chances are they're going to have high breast density for their age at 65. And this has important clinical implications because women could be identified, women at high risk could be identified through a single early screen. It's also highly heritable. Now, this is one of the papers that originally brought me over to Australia over 20 years ago, looking at twins. And we compared the breast density in identical twins. So you can see one axis is twin 1 versus twin 2. And you can see that they're highly correlated. If they were perfectly correlated, they would fit on all the dots would appear on a 45-degree angle, on a 45-degree line. As opposed to non-identical twins, you can see that the points are a little bit more random. And so then you do some whiz-bang statistics, and we estimated that about 60% of the very large variation that we see in breast density across all women is likely due to genetic factors. And then, of course, the next obvious question is, well, what are those genes? And there's a whole body of research trying to identify those, but we've estimated that there's about a 15 to 20% overlap between genes that are associated with breast density and genes that are associated with breast cancer risk. Despite being genetic, it is modifiable. And this is the main result from the IBIS-1 trial, where they looked at high-risk women and where half of the women were prescribed tamoxifen and the other half were prescribed a placebo. They measured their breast density before they started treatment, and then they measured their breast density again 18 months later and showed that the women on tamoxifen had much less breast density than the women in the placebo. And this was still true even at 54 months. So the next obvious question is, well, is that reduction associated with a reduction in breast cancer risk? And it was. So women who saw large reductions of greater than 10% in their breast density after being on tamoxifen, that was associated with a 63% reduction in breast cancer risk. So breast density can be used as a biomarker to monitor effectiveness of primary prevention strategies. And if a woman is on tamoxifen and sees a decrease in her density, over time, then that is indicative that the treatment is working. Unfortunately, tamoxifen is a fairly invasive drug. So I just want to, luckily there's been a recent study showing that low dose tamoxifen, 2.5 milligrams as compared to the standard dose, has also can reduce breast density in premenopausal women with fewer side effects. So this could have some real important clinical implications, assuming they can also show that that reduction is also associated with a reduction in breast cancer risk. And that's because it's been estimated that about 40% of premenopausal breast cancers and about 26% of postmenopausal breast cancers could potentially be averted if all women with heterogeneously or extremely dense breasts, in these two categories on the right, could be shifted to scattered fiber density, which is a BI-RADS B. That's because of course, it's reducing the actual dense material, which would reduce your risk, and also then reduce the or increase the likelihood that you would find it or see it on the mammogram. So switching, that was the end of my top 10. I'm switching now to some more of the issues that are associated with breast density, particularly its measurement. In the United States, the most common way of measuring breast density is through BI-RADS, and there's 4 examples here. These are the corresponding graph that would go with the earlier graph where you saw mostly fat, scattered density, heterogeneously dense, and extremely dense. It's a manual assessment by a radiologist in, like I said, in the US. All screening mammograms are assessed using BI-RADS breast density. The issue is that it is categorical. It's splitting something into 4 categories when it is a continuous measure. It is subjective as well, not just between radiologists, but also within radiologists. And it was designed to alert physicians about the reduced sensitivity of mammography. It was never designed to identify women at increased risk. There are now automated measures of breast density that either measure breast density from a 2D image or a volumetric image. There's some also measures of texture, and of course, leading to very novel AI or artificial intelligence-based measures of breast density. Well, they're not actually measuring breast density, they're just using all the information of a mammogram to not only predict who might get breast cancer, but also use to detect breast cancer at the time of screening. And in fact, this technology is actually being used in screening programs in Denmark. The issues with the continuous measures, of course, is that all these software cost money. You're talking about implementation within a publicly funded screening program. They're still not standardized. When you get a continuous measure of breast density, what does that mean, and how best can we use that information? So just a quick, want to show you how challenging it can sometimes be for the radiologist to do a BI-RADS assessment. Here we have an example where there's not a lot of density, like quantitatively, but it is very bright. So it's still sufficient to obscure small masses. So on the BI-RADS classification, this would be a C, a heterogeneously dense, not a B. But if you used a automated continuous measurement, an area-based measurement, it would be fairly below density because it's much less than 50% of the breast is occupied by dense tissue. A volumetric measurement might say that it's a bit more because, of course, it uses the thickness of the breast and takes into account those bright areas. And then a AI-based measure would presumably incorporate all of those things and not just the dense material, but all the artifacts in that mammogram to predict breast cancer risk. So this is an example of one of the automated continuous measures of breast density. This is using the Volpara software, and this is sort of a sample output of what it would look like at the time of screening. It also will estimate the BI-RADS categories. This is the BI-RADS B. And in addition to the BI-RADS, of course, it gives you this continuous measurement of dense tissue in centimeters squared for both breasts, the total volume of the breast, and then, of course, calculates the percent. Again, I indicated that there is, of course, cost associated with implementing the software. There's also logistical issues. The software requires raw images, not processed images, which means because breast programs don't normally store the raw images, it means double the amount of storage, and it's often sometimes increased bandwidth to share these images across assessment centers. And then there's, the interpretation of, well, what does it mean to have a Volpara measurement of 6%? There is no standardized score. All we have is the graph that I showed you previously, using the sort of proportions of women with the various different BI-RADS measures. To put it in context, we don't have what you know about bone, something similar to bone density. We're using a T-score, which compares all people's bone density to an average 30-year-old person. And if it has a T-score in a certain range, then that's indicative of low bone density or osteoporosis. Or even simpler, something simpler like a growth chart, where you can estimate the percentile of, in this case, height for a particular age. I think that would be very interesting or very useful clinically to put breast density measurements in a context. How does Breast Screen WA measure breast density? It is a dichotomous measure. So it's sort of loosely based on the BI-RADS, where heterogeneously or extremely dense breasts are considered dense, and the other categories are not. I'm sure many of you are familiar with this letter, that this is a routine results letter with this inserted paragraph informing women that they have dense breasts, and that's mammograms are significantly less sensitive in diagnosing breast cancer women and breast cancer in women with dense breasts, and it recommends women consult their GP. And so what should GPs do with this information? Well, I think it's becoming increasingly clear that breast density should not be used as an isolated risk factor. Like I said, it's been estimated that 43% of women aged 40 to 74 have heterogeneously or extremely dense breasts. Not all of those women are at increased risk for breast cancer. Not all of them will develop breast cancer. Identifying those most likely to develop breast cancer is challenging. So the recommendations are to focus on overall risk, to select screening strategies rather than just breast density, which better balances the benefits and harms of screening. Using the Breast Cancer Surveillance Consortium data in the US, women are likely to present with interval cancers. Women's most likely to present with interval cancers were women with an elevated 5-year risk for breast cancer greater than 1.67%, and representing about 24% of all women with dense breasts. So how do we know whether or not a woman has a 5-year risk for breast cancer greater than 1.67%? Well, there's tools like iPrevent. It's the breast cancer risk assessment and risk management decision support tool designed to facilitate prevention and screening discussions between women and their doctors. It was developed in collaboration between Peter Mac and the University of Western Australia. The computer scientist who co-developed this in collaboration with Kellyanne Phillips kindly lent me these next 4 slides. As you can see, it's an accepted clinical resource, and it also has recently been endorsed by Cancer Australia. It only takes about 30 minutes to complete an assessment, really depending on how much family history a woman has. It toggles between 2 validated risk assessment models, the Tyrer-Cuzick or the Boadicea model. And again, we'll use the best model depending on the information that you have available, particularly if you haven't had a genetic test completed. This is just a sort of a snapshot, I guess, of what the interface looks like. Very easy to, very straightforward. Again, the only onerous bit is when you have to complete the family history part. This part I really like. At the end, it tells you that your risk of developing breast cancer for the next 10 years is 4.1%. I think you can indicate whether or not a 10-year risk or a lifetime risk or 5-year risk, whatever you choose at the beginning. And it tells you this means that 41 out of 1,000 women your age with the same risk of breast cancer as you will develop breast cancer in the next 10 years. So, and then it tells you what the population risk is, and that's 36 out of 1,000. And I think these graphics are really useful because if you tell women that their risk is 4.1%, again, it needs context. So here we have 1,000 little women, and 36 is actually not a lot, and relative to 41. So it is an increased risk, but yet still quite small. And then at the end, women have the option to download a PDF of their lifestyle measures and for options to reduce their risk, and some screening options that they can take to consult with their GP. So I'm going to try something new. I've done this in person, but I've not done it online. So I'm going to try. I was going to try and I can't actually highlight. Okay, if you have a phone, you can presumably take a picture of the QR code and this website should come up. Sorry, here I was going through the various different procedures based on their appropriate criteria, appropriateness criteria category. And those in green are usually appropriate, that has the highest appropriateness rating, indicating it's a favorable risk-benefit ratio for patients. And then maybe appropriate, and then there's maybe appropriate with disagreement, which is too dispersed from the panel median. There's also then a relative radiation level. MBI and PET are nuclear medicine. The radiation dose for tomosynthesis or 3D mammography is slightly higher than a normal digital mammogram. So this is with high-risk females with dense breasts. The next two tables are similar, but on the top we have average risk females with dense breasts, and then intermediate risk females with dense breasts. So interestingly, for the average risk women with dense breasts, saying tomo is usually appropriate. Mammography with contrast or SESM may be appropriate, as is MRI or abbreviated MRI with contrast. Breast ultrasound, there's some disagreement about whether or not that would be appropriate, largely due to its high false positive and false negative biopsy rates. Then we have, I'll talk a little bit more about that in the next slide. Then we have intermediate risk, where they're saying, again, tomo is usually appropriate, and SESM, MRI with contrast, abbreviated MRI, and breast ultrasound may be appropriate. And again, I strongly recommend everyone to check this out. This reference is a fabulous reference. So just to sort of summarize some of the benefits and harms of supplemental screening. For ultrasound in women with dense breasts, it's only small improvements in cancer detection rates with supplemental ultrasound compared to mammography alone. All supplemental screenings cost more money. There's an associated cost. It has a very high false positive rate and false positive biopsy rate, resulting in a lot of unnecessary extra tests. For tomo, in a meta-analysis of 16 studies evaluating women with dense breasts, the addition of DVT improved the cancer detection rate compared with mammography alone in both diagnostic and screening settings. And it also has the added benefit of reducing recall rates. There is the added radiation exposure, and there's also significant increased reading time because, of course, as it is a 3D mammogram, there's multiple slices of potentially hundreds of slices that have to be measured instead of just one 2D image. MRI in women with dense breasts, supplemental MRI yields incremental cancer detection rates anywhere from 3 to 28 per 1,000 exams, depending on which paper you read. MRI is significantly more expensive, and availability is much less. And of course, there's also the need for gadolinium administration, which there's been increasing evidence to suggest that there's cumulative buildup on the brain of gadolinium. MBI in women with dense breasts, the addition of MBI to mammography increased the cancer detection rate by 7.7 to 8.8 per 1,000 women screened. Like I said, it uses gamma rays, so there's a significant radiation dose. And it is also associated with increased recall rates, so that if something does come up, it generally often requires additional tests. But there is MBI available here in Perth at the Hollywood Hospital. SESM, I believe, is also available at the Royal Perth Hospital in a diagnostic setting. SESM appears to have high sensitivity and high specificity, and the improvements compared to mammography appear to be highest in women with dense breasts. It uses a contrast agent, iodine. So what are some of the implications? of adding supplemental imaging to screening mammography. Well, like I said, all supplemental imaging will find more cancers. All these supplemental strategies cost money, and it's not just the financial cost. There's also a lot of anxiety, increased anxiety associated with increased tests and biopsies and false positives. Most of the cancers detected are small, no negative tumors. And so, of course, that raises the question of overdiagnosis, diagnosing cancers that would have not caused harm if went undetected. So I'm just going to switch gears a little bit and move on now to what women know and do about breast density. Looking at the impact of breast density notification on women who attended the Breast Screening WA program. We conducted a survey of nearly 7,000 women and compared the responses from women who were notified they had dense breasts versus those who had not. And we assessed their psychosocial response to the notification and their intentions to rescreen again in future. We also asked them what they did in response to being notified they have dense breasts and what subsequent advice they received from their health professionals. And these results have been published in a couple of papers, the third on the way. So just looking at the psychosocial response, 2/3 of notified women indicated that knowing their breast density made them feel informed. 21% described feeling anxious and 23% described feeling confused. More than 90% of notified women said that their experience being notified they have dense breasts did not put them off screening in the future, and that they intended to return for future mammography screening at Breast Screen WA. So we then looked at those 21% who said they felt anxious after being notified, and in fact 96% of them intended to rescreen when due. That's even higher than the 90% overall, suggesting that anxiety associated with breast density notification actually improves the likelihood of women screening, not the opposite. What did women do post-notification? Half of women notified said that they had consulted their GP or intended to consult their GP, particularly those notified for the first time. And of those notified women who consulted their GP, 50% self-reported to have been referred for supplemental screening. Overall, around only 20% of women notified as having dense breasts reported that they had an ultrasound due to their breast density. Now, these are, of course, self-reported estimates, and we have applied for future funding to link Breast Screen WA with Medicare so that we can actually empirically estimate what the uptake of GP visits and supplemental screening referrals or attendance. In the meantime, we have been funded by the Cancer Council WA as part of a Cancer Collaborative grant to form WA's first statewide general practice-based research network to improve engagement with GPs for collaborative research and facilitate direct dissemination and translation of research into GP practice. So one of the first initiatives of using the GPBRN will investigate GPs' understanding, or current understanding of breast density, and when and what influences their decisions when consulting women who have been notified they have dense breasts. And this is led by Dr. Jackie Frame, Ramna Ramnan, and Lucy Gills. So, like I said, the first aim will be to assess the current understanding of breast density. Second aim is to quantify the impact of breast density notification on patient management. I'm going to do this hopefully through manual audit of participating GP practices. We'd like to take all of this information and then hopefully co-develop in collaboration with GPs an optimal care pathway, which would include an implementation plan. So if at all is anyone's interested in being involved in this, in the GPBRN, or particularly in this study, please feel free to email Jackie. And her email is just there, or myself. This was supposed to be another part of my pop quiz, which again, I can't highlight anything when I'm in presentation mode, which is too bad, because I'd like to, again, sort of, if you can access using through the QR code, using your phone. The question is, when consulting a patient who has recently been notified she has dense breasts, what do you think is the most common outcome in your practice? And instead of highlighting one, you can sort of rank the answers to what you think is the most likely or the most common outcome when consulting women with dense breasts. So I'm going to finish up with a few slides about personalized screening. There is increasing evidence to suggest that to support, I guess, a movement towards tailored screening, whereby you would identify women at different levels of risk and thereby recommend different screening recommendations, whether or not different screening intervals or supplemental screening. And the idea is that this could be a more efficient and cost-effective way of detecting breast cancer. So just to give you an idea of why we might want to do that, well, this is the graph of the lifetime risk of breast cancer on the x-axis, and here we have the relative frequency of a population. The blue line represents the entire population. Of course, we have our average risk of 1 in 7, which is around 14%. The majority of women are all underneath this blue line, are below average risk. And then here we have, greater than 14 up to 20%. And that's where we talked about the intermediate risk. And then all the women under the blue line here, these are the high risk women, in which whom we would prefer to be targeting to identify their cancer earlier and avoid interval cancer detection. So in terms of research that's going on in the area, in terms of trying to identify what these screening recommendations should be for these women at different levels of risk, in the Netherlands, they have a multi-center randomized control trial of 40,000 women in the targeted age range of 50 to 75 with extremely dense breasts and a normal result after a screening mammogram. So women were assigned to receive supplemental MRI or the standard of care mammography screening in a 1:4 ratio. So had over 8,000 women who were invited to have the MRI in addition to the mammogram, and then 32,000 have just the mammogram. The primary outcome was the between group difference in the incidence of interval cancers during a 2-year screening period. So you can see here, this table is on the left is the main result. If you look at the intention to screen analysis, you can see that of the 8,000 women that were invited to have an MRI, there were 20 interval cancers. That's compared to 161 in the mammography only group. But then if you go down a bit further, you see that the actual number of women who actually took the invitation to have an MRI, and of those 4,783, there was only 4 interval cancers. The other 16 interval cancers were women who didn't actually have the MRI, which I find interesting that so many women refused to have the MRI. So anyway, the detection interval cancer rate per 1,000 screens is less than 1 for the women who had the MRI compared to, say, 5.1 for women with just mammography. So the conclusion was that the use of supplemental MRI screening in women with extremely dense breasts, that's a BI-RADS-D, resulted in the diagnosis of significantly fewer interval cancers than mammography alone during the 2-year period. There's also an ongoing WISDOM trial. We don't have the results from this just yet. It is a randomized trial to assess whether personalized breast cancer screening, where women are screened biannually, annually, or not at all, depending on their risk and their age, whether or not that can prevent as many advanced cancers as annual screening in women aged 40 to 74 across 5-year trials. So this is sort of a figure of the design. Women can either agree to be randomized or choose self-assignment, and women are in the age range of 40 to 74 with no history of breast cancer, and it uses again the Breast Cancer Surveillance Consortium risk model to assess risk, and it also incorporates a polygenic risk score. So very watch them eager anticipation. Here in Australia, we have Gordana alluded to the recent Centre for Research Excellence that I'm involved in. It's based at the University of Melbourne and led by John Hopper. It aims to take a holistic approach to breast cancer control by applying AI to, firstly, to develop a mammogram risk score. So again, that's using all the information in a mammogram to predict who's more likely to develop breast cancer and maybe even detect breast cancer at the time of mammography. Then to incorporate that mammogram risk score with like a polygenic risk score, and as well as a family history and any other personal data, and use all of that information combined to identify and target women at increased risk and who might benefit from early screening or maybe even some primary prevention strategies. And John Emery is the lead in terms of primary care, and John has recently returned back to Perth, and so we are collaborating together on working out how to best incorporate this into a primary care setting. So in summary, high breast density reduces the sensitivity of mammography because of its masking effects. It makes it very hard to see the cancers. And the sensitivity of mammography usually that exceeds 85% in fatty breasts, and it could decrease to as low as 65% in very dense breasts. Breast density also increases the risk of breast cancer. The relative risk for cancer in women with extremely dense breasts compared to the average woman is about 2 to 1. And like I mentioned, 30 to 40% of women over the age of 50 have mammographically, heterogeneously, or extremely dense breasts, and the majority of these women will not develop breast cancer. So it's our job to identify those that are at the highest risk. So GPs are recommended to assess their patient's risk for breast cancer before consider supplementary screening, perform a clinical breast examination, and discuss ongoing patient breast awareness for any breast changes. And as I'm sure you're all aware, Breast Screen WA provides a fact sheet and a lot of information for GPs online. They also have a fantastic GP liaison officer, Dr. Eric Kong, who can also ask any direct questions about breast density. So that's it from me. I'd like to thank you very much for the opportunity to speak to you today. Apologies about my attempts at doing something a little bit more interactive did not work. But if you have any questions, I'm more than happy to take them.
I just want to invite all the audience to submit their questions via the Q&A function at the bottom of your screen. I have 3 questions already from Dr. Eddy and from someone who is anonymous. Would you be able and kind to answer some of the questions, Professor Jennifer Stone?
Of course.
Yes. First, from Dr. Eddy, I think you already mentioned that several times, but still, in patients who are who want screening but don't want radiation exposure, could you safely do MRI scans instead of X-rays?
As a screening tool?
That's what.
That would
yes.
be a very expensive
as a screening
tool.
As a screening, yes.
Yeah, it's MRI is a very effective way of detecting breast cancer. As a screening tool, it's just not practical. And it's also incredibly expensive as well. So for an individual woman, they would have to be, independently, financially independent enough to be able to do that on a regular basis.
Yes, and you said it's already the ultrasound, the value of the ultrasound is questionable still.
Well, that's based on the latest, so if you, supplemental ultrasound is easily the most popular sort of recommendation currently, but the most recent ACR recommendations suggest that for women at average risk, that it's not necessarily highly recommended.
Yes, so still the mammogram is the best tool still.
Yeah,
so
and it suggests that TOMO, it would be a better test.
The second question from Dr. Eddy is that what is the impact of dietary phytoestrogens from plants?
Sorry,
The
say that
impact
again?
of dietary the impact of dietary phytoestrogens from plants. Probably on density, probably on breast density. Yes.
Yeah, okay. So there's not a lot of conclusive evidence to associate any dietary components with breast density.
Thank you. And now the last question that I have here. In fact, oh no, I have more questions. Sorry. Yes, I have some women with breast implants are quite reluctant to have mammogram for implant ruptured. Some people, they never go for mammogram due to that. In those who have breast implants with dense breasts with family history of breast cancer, could you please share any special tips in counseling them to have mammogram?
Well, the Breast Screen WA team are incredibly experienced with being able to screen women with implants. They just when scheduling their appointment, they just have to let them know that you do have implants, and therefore they will schedule a longer appointment time to ensure that it is as comfortable as possible and that they can get the best pictures. But yes, a woman with dense breast and a family history, that would imply that they are at increased risk, not just due to the density, but other risk factors.
Thank you very much. And then the next question is, why does, that's from Dr. Nigel Ledger, why does Breast Screen WA recommend that we do clinical breast examination in women with dense breasts? My understanding was it has not been shown to be helpful.
Yes, is the answer. Yes, there's not a lot of evidence to suggest that clinical breast exam is definitely not better than mammography or does not improve mammography. I think the messaging is more about women being breast aware and about noticing any changes in their breasts. And that's where clinical breast examination, I think, can be very useful because it's really about changes.
Thank you very much. Then the next question is, can you comment on tomosynthesis? Tomosynthesis, yes.
So can I comment just in general?
Yes, I think so, yes, or on the breast.
There appears to be some pretty impressive evidence to suggest that yes, it does find more cancers and improved sensitivity and specificity. I don't believe there's any evidence to suggest that it will find or reduce the interval cancer detection. It is also, there's issues with, and another benefit is that I said did lower recall rates, but it is also associated with significant increases in the reading time, because like I said, it's multiple slices of a mammogram, so you have potentially hundreds of mammograms to assess instead of just one 2D image. So in the United States, it's being used as a screening modality. Here in Australia, it's only being used as assessment in breast screen programs. So women who have had a digital mammogram are recalled for further assessment. They would then potentially receive a tomo.
Now, thank you. Does vaginal estrogen increase the risk of breast density? Vaginal estrogen, yeah. Probably the treatment with vaginal estrogen.
That's the theory, is that that it's a cumulative exposure over time to increased estrogens associated with dense breast density. It's incredible, so therefore incredibly difficult to actually measure estrogen and find association with dense breast, because it's not just, estrogen is highly variable across women and within a woman. So there's a whole concept about breast tissue aging, and the reductions in breast density are often associated with hormonal events like age at menarche, having multiple children, at what age you have your children, age at menopause. So yes, there is a theory about the cumulative exposure to estrogens and associated with the cumulative exposure to breast density, but actually proving that theory in terms of finding an association between a cross-sectional study where you look at estrogens and breast density, we have not found any conclusive evidence of association using a cross-sectional study. No.
Thank you very much. Now we have Mary Ellen. I suggest the mammogram report should be slightly changed. As a generalization, when women reads her mammogram is normal, I believe that many women don't read further than their breasts are dense and don't follow up. I suggest that normal and dense need to be put in the same sentence. would other SERMs potentially help reduce the risk of breast cancer in those used as HRT? That's two questions, sorry.
Two questions,
So-
okay. I'll talk about the
She's
HRT
suggesting that the report should be changed, and in one sentence, the report should say the findings and the density of the breast.
Yes,
And the other question is, would other SERMs potentially help reduce risk of breast cancer, i.e. those used as HRT?
okay. So the first question,
The report.
yes,
yeah.
I think there's a lot of women who read the letter and say, oh, I don't have breast cancer, and then they stop reading completely. If you have any ideas about how to fix that, let me know. So the routine results letter, it's a standard letter. That paragraph about just breast density is the one about breast density, but there are other conditions as well that can be inserted based on the, I think there's 11 other options that could potentially be inserted, not related to breast density. So it's, I think it's a challenge to try and particularly when you are talking about different culturally and linguistically diverse populations as well. When we did the survey, we noticed that it was a completely anonymous survey, but we did know which women were notified and which women weren't. And one of the first questions we asked is, you know, have you ever been notified of having dense breasts? And 14% of women who had been notified said, "No, I've never been notified." So they you know, there is definitely that tendency for women to not continue reading. And those that do continue reading, with their actual comprehension of it and what it really means, then there's multiple different reactions to that as well. Anything from, you know, extreme panic to like, oh, so what, and throw it in the bin. So it's impossible. Health literacy is often very challenging, and to get a consistent message to the majority of people in a way that is understood and without panic inducing, I think is very, very difficult. Your other question about HRT, I think, is whether or not HRT is associated with breast density, and yes, HRT is women on combined estrogen and progesterone therapy. It's associated with increased breast density and increased breast cancer risk as well. And it's also been shown that when women stop HRT, that their breasts will actually go back to normal ranges that they were before the treatment.
And Professor Stone, now, thank you very much. This is the last question. Oh, we have more. Is iPrevent available for use by GPs? Is it free, or is it by subscription? Sorry.
Totally free. Yeah. So just Google iPrevent and off you go. Please. Yeah, I encourage everyone. I have actually put the little link now in the chat. I'm not sure if everyone can see that, but yeah, if you can, it'd be great. And like I said, it's just two questions. One is, you know, whether or not you have are familiar with iPrevent, and whether or not you would consider using it in practice. And the other one was about what your current practice is with women who've been notified they have dense breasts.
Dr. Linda Cole has a question. Thank you very much. Have there been any studies of alcohol intake relationship with breast density?
Yes, so there is a positive association between alcohol use and increased breast density. Again, consistent with an association with breast cancer risk. So many of the risk factors that are associated with breast cancer are also associated with breast density. Yeah, the only, not an exception, they are age and BMI are of course associated with breast density and breast cancer, but in sort of opposite directions. It's called negative confounding. And that's because, again, I mentioned about the true risk factor being breast density for a woman's age, and breast density for a woman's age and BMI, if you're looking at their percentage.
Linda Cole is also saying we have a link to iPrevent from Health Pathways Breast Cancer Risk Assessment. She's just informing us. We have a link to.
You have the link. Yes, you're able to find it?
Yes, from Health Pathways. From Health Pathways, we have a link. GPs can have a link to the breast cancer risk assessment. Yes, that's Dr. Linda Cole. Then Dr. Fiona, I have patients who have seen breast specialists who advise patients with dense tissue to have both mammogram and ultrasound for screening every 2 years, or alternate yearly mammogram and ultrasound. Is it your opinion that this is inappropriate?
I think it depends on their other risk factors. So we talked about women at average risk, and according to the AACR appropriateness criteria, those women would not recommend breast ultrasound. But women at intermediate risk or particularly definitely high risk, it was considered appropriate.
I don't see any more questions. Are there any more questions, please? I don't see any. So I have just one question, if you don't mind, Professor Stone. Can we use it also as the prognostic factors? Can we see some prognosis out of this breast density as well?
So there's a lot of literature out there. Well, not that much. It's a bit inconclusive. We're trying to see whether or not women with dense breasts, whether or not they respond better to chemo, and also to look at better associated with recurrence and those sorts of things, and particularly in the neoadjuvant and the endocrine therapy and all that sort of stuff. So I'd have to do a bit of a lit review to see what's the most recent, because it's sort of a little bit inconclusive in my current head, but yet I'm not quite confident, I guess, not with the literature, to be able to comment on that at this stage.
No, I'm just asking that. That's from a GP point of view, those would be very practical questions, that's all.
Yes.
So then if there are no more questions, I don't see any, or maybe there are chat. Let's see. Just check. I don't think, I think that Professor Stone, you answer all our questions. And then thank you to our speaker. Thank to all of you who joined us this evening. There is also, Professor Stone, as the last request to you, some of these our GPs wanted to have your slides. Is that possible?
Yes, absolutely.
Okay. Would they contact us, or would you?
That's a good question. I can provide those to the conference organizers, the webinar organizers, and then distribute those. We'll figure it out how to get
yes,
those.
Absolutely, absolutely. Thank you so
recipients.
much for your valuable time, and this is valuable information and up to date. Thank you so much. I enjoyed very much, as I'm sure our audience.
Thank
Have
you
a
for
lovely
having me.
evening. Thank you.